Today's topic is multiple sclerosis. I am Dr. PARIDHI SHIVDE, Professor Medicine in MGM Medical College. Multiple sclerosis is a chronic disease characterized by inflammation, demyelination, followed by gliosis or scarring, and neuronal loss, mostly in white matter of both brain and spinal cord, and peripheral nervous system is not involved. As the name suggests, multiple. So there is multiple demyelinating plaques, and the main sites are brain, spinal cord, and optic nerve. There is demyelination, inflammation, followed by gliosis. Lesions of multiple sclerosis typically occur at different times and different CNS locations. Therefore, they are known as disseminated in time and disseminated in space. Dissemination in space is noted in MRI by finding a new lesion and an old lesion. Dissemination in space in MRI is found by involvement of different sites like spinal cord or brain like juxtacortical area, periventricular area or infratentorial area. Clinical features are heterogeneous depending upon location and severity of inflammatory lesions. There may be acute demyelination which fully or partially resolve, or chronic demyelination and neuroaxonal injury that are generally irreversible. Pathophysiology. There is blood-brain barrier disruption. Blood-brain barrier prevent entry of T cells into central nervous system, and due to the disruption of blood-brain barrier, there is leaks which causes swelling, activation of macrophages, cytokines, and destructive proteins. Multiple sclerosis is an autoimmune disease. There is myelin-specific autoantibodies are present. Remyelination occurs in early cases, but repeated attacks lead to fewer remyelination. There is inflammation. T cells attack on myelin, which further triggers inflammatory process. What are plaques? Plaques are multiple focal demyelinating areas in central nervous system, and they are associated with gliosis and inflammation. History of multiple sclerosis. First actual case was diagnosed in 1849. It was Dr. Jean-Martin Charcot who is credited with giving us the first signs and symptoms of multiple sclerosis. Epidemiology. It is a rare disease. Worldwide occurrence is 1.1 to 2.5 million cases. MS is more common in women, 2 to 3 times more prevalent than in men. Most common age of occurrence is younger age group, that is between 20 to 40 years. There is genetic predisposition, 1 to 3% risk of MS among first degree relatives. Genetic predisposition and environmental trigger causes immune attack and loss of myelin and nerve fiber. What are factors contributing for MS? Family history. A family history increases risk of developing MS. MS is associated with HLA-DRB1 gene. Race. MS occurs commonly in whites than Asians and Africans. Environmental factors. MS occurs most commonly in those living in northern climates and temperate zone areas. In temperate areas, access to sunlight is less and there is vitamin D deficiency. And vitamin D deficiency is a risk factor for multiple sclerosis. Infections. Researchers believe that many autoimmune diseases are provoked by some kind of infection that strikes people who have a certain genetic makeup. There is a strong association between multiple sclerosis and Epstein-Barr virus. There is a correlation between vitamin D deficiency and multiple sclerosis. Vitamin D deficiency is seen in patients of multiple sclerosis. Types of multiple sclerosis: relapsing remitting type, which is most common, account for 85% of the cases. Primary progressive MS, secondary progressive MS, and progressive relapsing MS. As we see in the first week, it is relapsing remitting MS. What are relapses? Relapses are when the symptoms of the patient flare up. And what is remission? Remission is a period of recovery when there is very less or no symptoms. So, there are relapses noted by these bars followed by a period of remission. So, in early cases, the relapses are followed by complete remission, and as we seen in pic 1, later in the course of the disease, relapses are not followed by complete remissions. There is incomplete remissions or incomplete recovery. In second pic, it started as relapsing remitting, and afterwards, later in the course of the disease, it becomes progressive. So, it has secondarily become progressive. So, it is secondary progressive MS. Then primary progressive MS, that is, it is progressive from very beginning of the onset of the disease. Relapsing remitting MS account for 85% of the cases. There are discrete attacks that generally evolve over days to weeks, and it is followed by complete or incomplete remission, during which person fully or partially recovers from the deficits acquired during relapse. Secondary progressive MS always begin as RRMS, relapsing remitting MS. There is a steady deterioration of function unassociated with acute attack. For a patient of RRMS, risk of developing secondary progressive MS is 2% each year. Primary progressive MS. 15% of individuals with MS are diagnosed with PPMS, primary progressive MS. Gradual progression from disease onset, and there are no overlapping relapses and remissions. Progressive relapsing MS. It is rare, seen in 5% of the patients. Initially, patient present as primary progressive multiple sclerosis. There is a steady progression of clinical neurological damage with superimposed relapses and remissions. So it is primarily progressive, and in addition, it has relapses and remissions also. Multiple sclerosis signs and symptoms. Symptoms of MS may occur in isolation or in combination. In isolation, the symptom which is very common is optic neuritis. Patient complain of visual blurring in one eye or vision loss. Or it can occur in combination, like patient have vision loss and also patient have myelitis. A clinical attack is considered if the symptoms are present for a minimum of 24 hours. This term we will use clinical attack, and it is that patient must have symptoms for at least 24 hours. Two separate attacks are considered in case when there is at least 30 days difference between onset of one attack and onset of another attack. Symptoms, we don't have to mug up all the symptoms, list of symptoms. We should remember the structures which are involved, that is brain, spinal cord and optic nerve. And we can know what can be the symptoms. So if brain is involved and cerebrum is involved, then patient can have weakness, patient can have monoplagia. If cerebellum is involved, patient will have ataxia, dysarthria, tremors. When spinal cord is involved, there is weakness, upper motor neuron type of paraplegia is there. There is sensory loss below the level of lesion, and there is bladder involvement. Patient can have urgency, retention of urine, can have bowel involvement in form of constipation, and also can have sexual dysfunction. In optic neuritis, patient will have decreased visual acuity, decreased vision, and in severe cases, patient can have vision loss. Clinical features: weakness of limbs, which is upper motor neuron type. It can be monoplagia and cerebrum involvement. It can be paraplegia and spinal cord involvement. Spasticity in 30% of the patients associated with muscle spasm. Optic neuritis, which is monoocular or unilateral. There is decreased visual acuity and may progress to severe vision loss. Here we should we should keep the differential diagnosis of neuromyelitis optica (NMO), in which optic neuritis is bilateral and here it is unilateral. Diplopia. Diplopia is not due to optic neuritis, it is due to internuclear ophthalmoplegia. What is internuclear ophthalmoplegia? It is impaired adduction in affected eye due to lesion in medial longitudinal fasciculus in the same side, and nystagmus is seen in opposite abducting eye. So on the same side affected eye there is impaired adduction, inability to adduct, and in the opposite eye which is abducting is having nystagmus. This INO, internuclear ophthalmoplegia, is seen in young patients in case of multiple sclerosis, and in older patient it is seen in ischemia. Diplopia is double vision. Sensory symptoms. Patient can have paresthesias, unpleasant sensations, and pain. Pain is present in more than 50% of patients. Cerebellar symptoms if lesions are present in cerebellum. There is ataxia, dysarthria, tremors. Bladder dysfunction is noted in more than 90% of the patients. There is incontinence, urinary retention, hesitancy, urgency. Constipation in more than 30% of patients and bowel incontinence in 15% of patients. Cognitive dysfunction, memory loss or dementia. There can be impaired attention, difficulty in executive functioning and problem solving. There may be euphoria also. Depression is a very common complaint. It is present in nearly 50% of patients. Fatigue is present in 90% of patients. It is most common cause of work-related disability in multiple sclerosis. There may be facial weakness, vertigo, and sexual dysfunction. Ancillary symptoms or supportive symptoms. Lermite sign. It is an electrical sensation that runs down the back and into the limbs and is produced by bending the neck forward. So from the neck there is electric sensation which run down the back and into the limbs. Heat sensitivity. Neurological symptoms produced by elevation of body's core temperature. Example: unilateral visual blurring may occur during hot shower or exercise. It is known as Uthoff symptom. There may be paroxysmal symptoms. In paroxysmal symptoms, there is brief duration alteration of consciousness. Brief duration, that is 10 seconds to 2 minutes. High frequency, alteration of consciousness. It may include tonic contraction of limb, face, or trunk, paroxysmal dysarthria and ataxia, paroxysmal sensory disturbance. Clinically isolated syndrome, that is only one attack, one clinical attack has occurred. So, definition is first clinical CNS demyelinating event lasting for more than or equal to 24 hours, which is consistent with MS, but is isolated in time. It is not disseminated in time. Only one attack is there and may or may not be isolated in space. So when we see the MRI, there can be two lesions. It may be, it not may be isolated in space. It is not fulfilling criteria for multiple sclerosis. Presentation of clinically isolated syndrome CIS include either there may be optic neuritis, cerebellar syndrome, spinal cord syndrome, or cerebral hemisphere lesion. Many patients remain asymptomatic for several years after this first attack. So there is difficulty in diagnosis in cases of first attack. Triggers that exacerbate multiple sclerosis. Temperature. Since raising the temperature shortens the duration of action potential, one of the early signs is improvement in cooling and worsening by hot bath. Infections or trauma may actually worsen the disease. Smoking, pregnancy, especially after birth. What investigations we should do? We should go for CSF examination, which shows oligoclonal bands, which assess intrathecal production of immunoglobulins IgG. There may be two or more oligoclonal bands which are present in 75 to 90% of patients. Other findings in CSF can be mildly elevated cells and proteins. Blood examination. In blood examination, we do these tests to rule out disorders that mimic multiple sclerosis, like antiphospholipid syndrome, HIV infection, sarcoidosis, syphilis, SLE, vitamin B12 deficiency causing subacute combined degeneration of spinal cord, and vasculitis. So we go in blood, we go for ESR, vitamin B12 level, folate level, vitamin D level, as vitamin D deficiency is a risk factor, antiphospholipid antibody, RA factor, anti-CCP, ACE levels for sarcoidosis, HBS antigen, anti-HCV antibodies, HIV, ANA. If ANA is positive, anti-dsDNA can also be done. MRI of brain and spine. MRI rule out other conditions like stroke and brain tumors which mimic multiple sclerosis. MRI shows many plaques in spinal cord and brain. Characteristic abnormalities are present in more than 95% of patients. Evoked potential, like visual evoked potential. There is abnormality of one or more evoked potentials is found in 80 to 90% of patients. Evoked response potential detects slow or abnormal conduction in response to visual, auditory, or somatosensory stimuli. Visual evoked potential is used to assess visual pathways through optic nerve, and it is used to detect optic neuritis. Oligoclonal bands in CSF seen in multiple sclerosis. They are not common in early cases. There are McDonald criteria for diagnosis of multiple sclerosis. And here we are seeing MRI diagnosis. There are terms used are dissemination in space, DIS, and dissemination in time, DIT. These terms we will use in next table, which is diagnostic criteria for multiple sclerosis. In short form, we will use it. So, dissemination in space by detecting involvement of at least 2 of 4 MS typical regions of CNS. These 4 are MS typical sites, and there should be at least 2 lesions, there should be 2 sites should be involved at least out of these 4 sites. So, these sites are periventricular, juxtacortical, infratemporal, and spinal cord. So 2 out of 4 MS typical regions should be involved. Dissemination in time, that is damage occurred on different dates. Dissemination in time can be established in 2 ways. A new lesion when occurred when compared to previous lesion irrespective of timing in reference to baseline scan, T2 bright lesion and or gadolinium enhancing lesion. Presence of asymptomatic gadolinium enhancing lesion and a non-enhancing lesion at any one time. These are McDonald criteria, revised McDonald criteria for diagnosis of multiple sclerosis. And this is a complicated criteria. I have tried to make it simple. It depends on clinical attack, number of clinical attack, number of objective clinical evidence of lesion, and then diagnosis. So first is if clinical attacks are 2 or more and objective clinical evidence of the lesion that are signs are 2 or more, then the data needed to make a diagnosis of multiple sclerosis is none. Only MRI should be consistent with multiple sclerosis. So it was simple. Second one, if clinical attack are 2 or more and objective clinical evidence is 1 only, then we have to show by MRI dissemination in space, DIS, or we should wait for a further next clinical attack implicating different site to make a diagnosis. We should wait for a new attack to make the diagnosis. Then third one, if clinical attack is 1 and objective clinical evidence is 2 or more, then DIT, dissemination in time, should be demonstrated by MRI as we have seen in last slide, or we should wait for second clinical attack, or we can see CSF oligoclonal bands. So by either of these ways diagnosis can be made. Then second last is if clinical attack is only 1 and objective clinical evidence of lesion is also only 1, then we need both DIS, dissemination in space, DIT, both is needed, or we should wait for a second clinical attack to make the diagnosis. Then last is insidious neurological progression suggestive of multiple sclerosis. 1 year of disease progression plus DIS, dissemination in space, in which 2 criteria out of these 3 should be present. These 3 are 1 or more T2 lesions in brain, 2 or more T2 lesions in spinal cord, or CSF oligoclonal bands. Out of these 3, 2 should be present and 1 year of disease progression should be present. Differential diagnosis, neuromyelitis optica. Neuromyelitis optica, also known as Devick's disease. As the name suggests, Myelitis optic, neuromyelitis optica. Myelitis is inflammation of spinal cord, and optica, that is optic neuritis, optic nerve involvement. So there is demyelination of spinal cord and optic nerve, and brain is not involved. What is the difference here? Myelitis in NMO is transverse, whereas myelitis in multiple sclerosis is partial and it is short segment. Myelitis in neuromyelitis optica is long segment. So myelitis in neuromyelitis optica is transverse and long segment, whereas in multiple sclerosis it is short segment and partial. Optic neuritis. Here it is bilateral, in MS it is unilateral. Antibodies against water channel protein aquaporin 4 is present in 60 to 70% of the patients. In MS, CSF oligoclonal bands were present. Treatment in acute cases by IV methylprednisolone. In chronic cases, azathioprine, mycophenolate, mofetil. Conditions mimicking multiple sclerosis. MOG, antibody disease. What is MOG antibody disease? It is a newly coined disease, that is myelin oligodendrocyte glycoprotein antibody disease. There is antibody against myelin oligodendrocyte glycoprotein. It mimics MS and NMO. There is inflammation and demyelination, mainly optic neuritis. Transverse myelitis can also be there, and brain involvement also occurs. Anti-MOG antibodies present in CSF. MRI findings. It is showing multiple demyelinating plaques of various sizes. This is Dawson's finger, name given for multiple sclerosis lesions around ventricle-based brain veins. Here also multiple demyelinating plaques are seen. Then in spinal cord. Spinal cord, it can be short segment in MS and long segment in transverse myelitis and neuromyelitis optica. In multiple sclerosis, there are two short segment demyelinating plaques are present. Two lesions are present. Here, in same patient, in brain there are multiple lesions, and also there is a short demyelinating lesion, short lesion in spine also. Neuromyelitis optica, where there is long segment lesion is there, long segment demyelinating lesion is there, and here brain is not involved. Acute treatment of multiple sclerosis, acute episode should be treated with steroids. Methylprednisolone 1 gram per day IV should be given for 5 days, followed by tapered oral prednisolone. Disease modifying therapy that suppresses immune system at various level by various mechanism of action. It is a specific therapy. Immunomodulator therapy for relapsing remitting MS, which is FDA approved. Interferons, which are given injectable. Sphingosine 1-phosphate receptor modulator, fingolimod. Monoclonal antibody, natalizumab, alemtuzumab. Miscellaneous immunomodulators, glatiramer acetate, mitoxantrone, teriflunomide, and dimethyl fumarate. This teriflunomide and dimethyl fumarate are relatively newer drugs and are given orally. So they have advantage of being given orally. This immunomodulator therapy, it reduces frequency and severity of clinical attack and also slows progression of disability. What are first line and what are second line DMT? First line are interferon, glatiramer acetate, teriflunomide, and dimethyl fumarate. What are second line? Second line are mitoxantrone, natalizumab, and alemtuzumab. First line drugs have moderate efficacy and high safety. Second line drugs are more effective but have more side effects. When not to start disease modifying therapy. Not in all the patients we should start disease modifying therapy. So when not to start? CIS, clinically isolated syndrome, only one attack, with favorable prognostic factors, when prognostic factors are favorable. What are unfavorable prognostic factors? Unfavorable prognostic factors are short inter-attack interval. When attacks are when frequency of attacks is very less. More residual disability. Progressive course from beginning. And late age of onset. Usual age of onset is 20 to 40 years. Or when RRMS, relapsing remitting MS, with no relapse in last 2 years, no disability, no evidence of MRI activity, then there is no need to start DMT now. Progressive MS with no relapse or evidence of MRI activity. Pregnancy planning, because it is contraindicated in pregnancy. High risk of low adherence to treatment. When to start first line disease modifying therapy? When clinically isolated syndrome with unfavorable prognostic factors, RRMS with one relapse in last 2 years but less than 2 relapse in last year. So in last year there should be less than 2 relapses, but in last 2 years there is one relapse. Low residual disability and active MRI. When to start second line therapy? RRMS with 2 disabling relapses in last year and progressive form of MS with relapses and or active MRI. Interferons, which are given subcutaneously alternate days, it has side effects of flu-like symptoms, depression, hepatotoxicity. Dimethyl fumarate, which is given orally, and its side effects are angioedema. Fingolimod, natalizumab, alemtuzumab are second-line drugs. Mitoxantrone, which is given in IV infusion once in 3 months. It is cheaper drug, but it has more side effects. Amenorrhea, cardiotoxicity, leukemias can be there. Teriflunomide, it is orally given once daily. It can cause hepatotoxicity, teratogenicity. Teriflunomide is its efficacy is similar to interferons and also dimethyl fumarate. Off-label drugs. So, off-label drugs are azathioprine, cyclophosphamide, other drugs like methotrexate, rituximab. So this cyclophosphamide and azathioprine, especially azathioprine, is used by clinicians, though it is not registered by FDA. Azathioprine is less costly, safe, and is oral drug, but there are lack of studies for it. In some studies, it is found that it is non-inferior to interferon in relapsing remitting MS. As a general rule, available disease-modifying therapy have favorable impact on relapsing remitting MS while have no significant benefit in progressive MS, in which neurological disability continues to worsen over time. So diagnosis at correct time should be made. Who is right patient for treatment? Early relapsing remitting MS, clinically isolated syndrome with high risk MRI, disease modifying therapy are contraindicated in pregnancy, and mitoxantrone is only drug approved for progressive multiple sclerosis. Early treatment may alter natural course of multiple sclerosis. This is window of opportunity. Treatment at diagnosis. So we discussed specific therapy, now symptomatic therapy to relieve symptoms of patient. For spasticity, we can give baclofen, tizanidine, diazepam. For optic neuritis, for acute attack, methylprednisolone followed by oral steroids. For fatigue, amantadine. Amantadine is antiviral drug and its mechanism here in fatigue is not very clear. Then cognitive problems for dementia. Donepezil is used. For paroxysmal symptoms, that is alterations of consciousness, carbamazepine, phenytoin and gabapentin is used. Tremors. For tremors, clonazepam, misoline and propranolol can be used. Symptomatic therapy. For bladder dysfunction, propenthelin, oxybutynine chloride, prophylactic antibiotics for urinary tract infections. For constipation, stool softeners or laxatives can be used. For neurologic pain, carbamazepine, gabapentin, phenytoin, pregabalin, or tricyclic antidepressants can be used. For heat sensitivity, avoidance of heat and air conditioning should be done. This is summary slide. So as we split the name multiple sclerosis, multiple demyelinating plaques are present at multiple sites like brain, spinal cord and optic nerve. Sclerosis is scarring which is due to inflammation and demyelination. It is an autoimmune disease. Investigations. Demyelinating lesions in MRI brain and spinal cord. Oligoclonal bands in CSF and abnormalities of visual evoked potential makes the diagnosis. And we should use McDonald criteria for diagnosis of MS. Treatment is done by methylprednisolone in acute cases, specific therapy interferon injectable, teriflunomide and dimethyl fumarate are oral, and mitoxantrone which is usually used in secondary MS, in progressive MS. Thank you. Please like, share, and subscribe.